welcome you all to this exciting and enriching session under the banner of Medusane Medmemorate 25. Medusane, as many of you know, is more than just a student network. It's a powerful platform that has been nurturing young medical minds for the past 5 years. Built on the vision of collaboration, empowerment, and innovation, Medusane has become a trusted name for delivering medical knowledge in the most accessible and inspiring ways. Through medicine, students across the country have found not only a community, but also a stage to grow, share, and lead. And today, as we mark the journey with MedMemory 25, we continue that tradition of learning with passion and purpose. Now, coming to the highlight of this session, we are truly honored to have with us Dr. Aditya Cibi Chakravarthy, sir, a name that resonates with both clinical brilliance and teaching excellence. Dr. Cibi Chakravarthy sir has completed his MBBS and MD in General Medicine from the esteemed Kadalur Government Medical College. He then went to pursue his DM in cardiology from the prestigious Sri Jayadeva Institute of Cardiovascular Sciences and Research, one of the top cardiac institutes in the country. Adding to his list of incredible achievements, Sir secured an All India rank of 12 in NEET Super Speciality examination, a testament to his hard work, dedication, and mastery of the subject. He is widely known for his dynamic teaching style, his deep understanding of cardiology, and his ability to break down complex concepts into clear, practical insights. Whether it's a classroom or a conference, he brings a spark that keeps every learner hooked. Today's session focuses on a topic that is not just relevant, but absolutely life-saving, that is ECG and ACLS, Advanced Cardiovascular Life Support. Let's be honest, we have all had that moment of confusion where reading an ECG or recalling those ACLS steps under pressure. But this session promises to clear those clouds and give you a crisp clinical edge. So get ready to decode those tricky waves, sharpen your resuscitation instincts, and feel a lot more confident about handling real-life emergencies. With that, let's give a warm virtual round of applause and welcome Dr. Aditya Cibi Chakravarthy, sir, to take us through this high-voltage, heart-healthy session. Sir, over to you.
Yeah, thank you, Neeharika. Those kind words. Okay, as was introduced, today's discussion will be about ACLS. A lot of you, maybe MBBS students, you may not have actually seen a real life patient or actually endangered a real life situation of requiring ACLS, but definitely every one of you will eventually come into this, meet this situation. So our discussion here will be about what is the ACLS problem and what are the ECG interpretation, how to do a defibrillation, how do you manage the airways. All this discussion will be done in this video. So we will start with first, before going into ACLS, which means advanced cardiac life support, we should know what is the BLS, the basic life support. So suppose, imagine you are in a public setting or outside your hospital. You see a patient who is suddenly lost conscious and has fell down. You are being called as a doctor. You have to go and help the patient. So what will you do? So that is where BLS comes into picture. It is for both doctors and it is also for a general layman. So first thing first. First, you have to verify the scene safety. This is very important because the patient may be electrocuted. He may have touched a water which has electricity passed in it. He may have touched it and he may be electrocuted and he would have lost his consciousness. So before going and helping, you must first protect yourself and you should verify the scene safety. And after verifying the scene safety, you're going to the patient, you're touching the patient, and first check for response. Touch him, try to wake him up, ask him what is his name or a few questions, look for responsiveness. If there is no responsiveness, then you should shout for help. Let's not call for help, just shout. Whoever is nearby, you just shout that a patient is very bad and you need to help him. You shout, take the help, let whoever neighbors come near, and you just activate the emergency response. In here, in India, you used to call 108, where the ambulance service comes in. Or if you are in a probably a mall or some setting where an proper AEDs are available. So what is an AED? AED means it's an automated external defibrillator. It's just a machine where it is kept over, the paddles are kept over your chest and it will automatically sense your ECG and give a shock. So if you are in a setting where that is there, you should send someone to bring it, because there are two important things in BLS success. The first thing is doing an effective CPR, and second thing is early defibrillation. Only these two things will really matter whether it's live patient is going to live or die. You have to do CPR, and that too effective CPR. We will see in the next slide what is an effective CPR. And second thing is that you should go for early defibrillation. So early defibrillation literally means you just most of you would have know what is defibrillation. For those of you who don't know it, you have to keep a paddles over your chest and give a electric shock. So that will whatever rhythm is going in the heart will stop and then it will restart. So these two things should be done as fast as possible, and that is the most important part of BLS. So then you go and assess the patient. You assess two things: how is he breathing, and second is the pulse. So breath and pulse are the two things you assess, and this should be done within 10 seconds. So you should not go and keep pressing, look for the carotids or look for the brachial. If you check for the pulse, if you don't feel the pulse, you take 10 seconds. If there is no pulse, then you should start acting. So the more time you waste, for every 1 minute you lose before resuscitation, there is 6% increased chance of mortality. So you should go see the patient, whether look for his breathing, look for his pulse. Patient is breathing well, pulse is good, the patient is okay. If the patient has got no breathing and no pulse, then you have to worry about pulse. Circulation is more important than airway. That has been the change from the past guidelines. Because in a cardiac arrest patient, why do we do CPR? So that your brain and your heart gets perfused, and with oxygen. So if you oxygenate the patient and the patient's heart is not pumping and the blood doesn't go to your brain or to your heart, there is no point in just oxygenating. So circulation comes ahead of other airway or breathing. This is the first point I need to get into. So it is always circulation first, and then the airway, and then the breathing. So you should start performing CPR and do the AED, the two goal things. So in CPR, in AED, what does AED do? AED literally means you just keep a two paddles over your chest. Then you'll come with a box. Behind the box, there will be two paddles. You just open it, keep over the patient's chest, one over one anterior and lateral aspect, and that will record the ECG and it will give you a call, shock or not shock. It will just give you guidance. If it gives shock, then you have to press the shock button and the shock will be delivered. So basically, if it is shockable rhythm, you have to shock, and immediately after shocking, you should start giving CPR. You should not give a shock and just wait and look, okay, ECG is coming better. That's a common mistake everyone will do. You shock, you do the CPR. And then after 2 minutes, you again recheck. If the patient's improving, well and good. If it not, again you repeat the process. So shock and immediate CPR and circulation over airway and breathing. These are 2 points you should know. Then you have other group of rhythms, non-shockable rhythms. We'll come into it, what those. And that you just have only one option. You have to give CPR. And then you should wait for help to come. So these two things should be done. And CPR should be continued until the patient starts to move or some emergency person comes to help. So these two things you have to continue CPR. So this is what happens when you don't breathe and there is no pulse. Okay, the patient is pulse is there and patient is just not breathing, then you just have to give respiration. That you provide by giving one breath every 6 seconds and up to 10 breaths a minute. 6 to 10 breaths per minute you have to give. That is how you do it. So so BLS is the same thing. You go to a place, you see a person lying down. First, verify scene safety. Then second thing, go and assess responsiveness. Two things: the pulse and the breathing. If the patient is not responding, shout for help. And then if there is a mall or some days, ask the patient to someone else to get the AED, and then you start CPR. If the patient is not breathing and there is no pulse, you start the CPR, and if the AED comes, and use it as soon as possible. And if it is a shockable rhythm, you may have to press the shock button that will deliver a shock. But irrespective of that, you have to continue CPR and continue this till the patient becomes conscious or till help arrives. This is what you should do. Or if you see the pulse and just provide rescue breathing, that is what you should do. This is the basic life support. Now we'll go into the topic proper, that is the advanced cardiac life support. So for that, you should know two things. What is the quality CPR? This is very important. So a lot of ways, if you go to the hospitals, the government hospitals, a lot of interns will be giving CPR. But majority of the time, it will be just someone standing on the top of the patient and giving. This is the wrong way of giving CPR. Remember, the heart is not functioning. You are pressing the heart so that that is only maintaining the cardiac output. For that, how you can, if you just press mildly, nothing will happen. And if you press too hard, also it's not going to serve the purpose. So it has to be correct CPR. And what is the correct CPR? That means 1 minute you have to compress 100 to 120 times. That is, this is the compression rate is very important. And second thing is the depth of compression. You place the both the hands over the patient's lower part of the sternum. That should be placed, and your elbows should not be flexed. It should be straight, and the force should come from your shoulder. Not, you should not give force from your elbow. It should be your hand should be straight. Both the finger arms over the patient's lower part of the shoulder with a straight elbow, and force should come from the shoulder part. And this should be 2 to 2.5 inches in depth, around 5 centimeter in depth. It should go. And most important, this is the common thing which people used to miss. Once you give a compression, you should allow the chest to recoil, because what you are giving compression is the systole, this is the heart's contraction, and what how do you come back is the diastole, that is heart's relaxation. So compress, come back, compress, come back, and that should be done fastly at a good depth, and it should be non-interrupted. You should never interrupt your CPR. If you are not able to continue CPR, then you keep exchanging between persons, but never stop CPR before attending the ROAC, because this is the only thing that is taking over his entire circulatory functions. And as I said earlier, the hand position should be two hands interlocked over the lower half of sternum. And the how do you compress and how much do you give breath? As I said, the breath should be around 6 to 10 breaths in a minute. This is if you put some advance, or if you intubate the patient, or if you put a supraglottic airway. If not, for every 30 compression, you have to give 2 breaths, or for every 15 compression, you have to give 1 breath. So 15 times you compress, you give 1 breath. If you are a single operator, if two operators, then you can definitely take turns. So then other part will be the airway management. Now you have taken part of the circulation. This next important thing is the airway management. So airway management is, first thing is you should maintain, the goal is to maintain a patent airway. So what do I mean patent airway? Your airway, nothing should be obstructing from your nose through your trachea. The pathway should be clean. So first that, for that we do few maneuvers. This depends on what is head tilt and chin up, chin lift. This is your head has to be tilted back and chin has to come forward, and you have to give a pressure here. That is called as the jaw thrust. If you have a C-spine injury patient, this is very important. If an road traffic accident patient has a cervical spine injury, in that case, you should not do a head tilt and chin lift. You have to do something called as jaw thrust, basically pushing the jaw forward. So all this is done to open up the airway. So if you are in a hospital setting, you can do something further also using an oropharyngeal or nasopharyngeal airway. I'll show the image. This is the oropharyngeal airway, oral airway, which commonly used in hospitals, and this is the nasopharyngeal airway, the middle one, and this is the oropharyngeal airway. The purpose of putting this airway is to keep the airway patent, so that when you give bag and mask ventilation, the whatever air you give doesn't get the air pathway doesn't get compressed. It is patent, and the oxygenation is able to do. The other thing is, second thing, most important thing is the bag and mask ventilation. So what do you mean by bag and a mask? So see, this is the mask, and this mask will be placed over the patient. Consider this is the patient's face. Over this is his nose area, and this is his mouth area. This mask should be perfectly fit across his nose. It should be like this. And then there should not be any leak. If you keep it, it should be tight. It should not be leaking air. Whenever you keep pressing, the air should not come by the side. So it has to be fixed properly. For that, we use that C. It should be using this letter C, that should be hold to seal the mask to the face. And then you have to do that head lift, chin lift, which I told previously. That should be done with 3 fingers. So, and then you should, this is the bag, reservoir bag, which will have continuous oxygen supply, and this is the self-inflating bag, which you press to give the air. When you press this bag, air will go here through this thing into the patient's mouth. So basically, patient is not breathing. You keep a mask over his mouth, and you bag him, and you should not be bagging him very violently. As I said earlier, it should be just 6 to 10 breaths in a minute. Simply, if it should be 6 to 10 breaths in a minute. And for if you are doing compressions, 30 compression should have two breaths, or 15 compression, one breath. That should be the goal. And also, you should not be inflating too much. You have to inflate just around 600 ml tidal volume. That's it. Look at his chest. When you inflate, his chest has to just slightly increase in size. It should not be going out and come. Slight increase, just to maintain the oxygenation. That's it. And then if you are not able to maintain its saturation by using bag and mask and oral airway, then you go for advanced airway, where they put the endotracheal intubation. This is the ET tube. So this is the ET tube, and this will be passed through the patient's oral cavity, through across the larynx and into the trachea. It will be done through video assisted or through direct visual laryngoscopy. So if a patient is not breathing with oral airway, with bag and mask ventilation, if his saturation is not improving, if he's not becoming conscious, if the patient's ABG is too bad, then you will have to intubate the patient. So, as I said earlier, airway management, if the patient is not intubated, it should be 30:2. If the patient is intubated, it should be 10 breaths per minute. And tidal volume of around 600 ml is sufficient. And you should not do over ventilation, because that is also bad. It can, if when you give more pressure, your intrathoracic pressure will increase. So, what happens as the pressure increases? Our blood return from your lower body, our venous return will come down. So that will further decrease the cardiac outputs, further decrease the blood pressure. So avoid overzealous bagging. Another thing is that you should avoid any gastric distension is also possible, because the air which we go, we can distend the stomach, and that will cause reflux, and that will cause gastroesophageal reflux, and that can go into your lungs and cause aspiration pneumonia and all those problems. So these are the problems with bag and masking. And once bag and mask fails, your next option is endotracheal intubation. So most of you would have known what is intubation. If you are not knowing it, it is what I said with it. This tube will be used to protect your airway. This is the ET tube. So this tube will have this area will be inflated with a balloon, and this will inflate and hold its position beyond the vocal cords. You have a port for inflation, and this will come out. You will connect your ventilator to this area, and this area will be inside, and this bag will keep it in position. So, and also will prevent the aspiration. So this is what intubation is. So, and you will go to their important part of the ACLS. So first thing, you just have a look at this ECG. Uh, Most of you would be knowing ECG, or there will be a difference in knowing. We'll go slowly. So what is obvious in this ECG? I'm not going to go in detail. I'll just show the obvious finding. If you see this is a normal area, and you compare this to what is the obvious change? You can see that this is the P wave, and this is the Q, this is the R, and this is the S, and this is the T. You can see the ST is going up. It should have been normally coming down. Here ST segment is going up. So this is an example of ST elevation. Even more profound, you can see this area. You can see this as normally should have been here, but it is this much height. The waveforms going up is ST elevation, and ST elevation you can see in V2, V3, V5, V6, V4, and this is what is called as anterowall MI. To be precise, it's anterolateral wall MI. You can see in V1 and AVL also. So this is ST elevation MI, anterolateral wall MI. When you find this ECG in a patient, then what you should do? You should immediately give him a loading dose, activate the cath lab, and ask him for taking for primary PTCA. If that is not possible, you should give thrombolysis. If you're in a tertiary setup, you should thrombolyze the patient. That should also come into your picture. And next one is another. You can see same ST elevation in a different leads. Lead two. This is the lead two. This is the lead three, and this is the lead AVF. If there is ST elevation in lead 2, 3 AVF, we call this as inferior wall MI. You can see here the chest leads are all normal. You can see here the chest leads are all abnormal, and here the chest leads are all normal. It's only the inferior leads that is elevation. So this is an example of inferior wall MI. Again, the management is pretty similar to what I said in the previous ECG. And the third thing, this is also something which may not look as alarming as your previous ECG, but is also bad. You can see this focus on lead V1 and lead V2. What is happening here? Normally, you saw the other leads, it is going up. Alva. Now here you see it is going down. It is like biphasic. It is initially going up and then coming down. It is seen in it is going up, coming down. This type of pattern of ECG, where a patient who presents with chest pain and has this ECG, you have to think something called as valence. That is an example. This is also a heart similar to it is a myocardial infarction. This is also an MI. So you have to take this also into serious account. The other ECG, this is T wave inversions. The other ECG, if you look at this ECG, what is grossly different in this ECG to that ECG? Here you can see, look at the STs. This is the P wave, Q, R, S, and T. So look at this waveform and this wave. It is look at this and look at this. So what is obvious here? Your STs are coming down. So that is called as ST depression. So look at this is your wave area. It is coming so far down. So this much drop is what is called as ST depression. When you find such an ECG where there is ST depressions everywhere, and you can see here, 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 here. Only place where it shows ST elevation is AVR. This is also a dangerous type of ECG, which is suggestive of left main coronary artery disease. It is one of the most severe forms of ECG. I am showing this four ECGs because these are the most critical type of MI ECGs which you should never miss. See, ST elevation is something you should never miss because if you miss the diagnosis, the patient is untreated, then the results would be very bad. Same with all four ECGs. All four ECGs are deadly. The first two are very severe, complete total occlusions, and this is also almost subtotal occlusions. So this is what you have to know for MI point. So I'm now coming into this ECG. So what is your basic inference of this ECG? Compare this ECG to something like this. The first obvious thing is that you can see it is very wide. You saw all the ECGs were very narrow, but this is very wide. So this is the first thing you should remember. If you have such wide complex tachycardia, it is more or less it should be a ventricular tachycardia. So ventricular tachycardia is the one of the worst forms of malignant arrhythmias. So if a patient has ventricular tachycardia, that means his heart is not beating properly. It is just shivering. So your heart rate is too high. If you see, you look at here, the waveforms are they're a little wide apart. But you look here, waveforms are very narrow. That means what is this? Your heart rate is too high. Heart rate is around 300. So that means at that heart rate, the heart won't compress effectively. So when you have this ECG, when you find this ECG, it means it's a VT. Then you have to do two things. If the patient is hemodynamically unstable, that means if you can't find the pulse, if his BP is not there, you should directly go and cardiovert this patient. DC cardioversion. Cardioversion means it's an electrical cardioversion. And look at the other ECG. What's the difference here? It is even more, heart rates are even more higher. And it is definitely, you can see it is not monomorphic. All waveforms are of different shapes. One is taller, one is smaller, one is taller, one is taller. So this form of ECG, which you have, it is also called as a polymorphic VT. Again, here also you should shock. DC cardioversion must be done in these patients also. The third ECG, when you have such ECG, what is this? You can see this ECG is finally going back into this. So this is a polymorph VT finally degenerating into a ventricular fibrillation. So this is called as a ventricular fibrillation. When you find such ECG, what you should do? Your aim has to be immediate DC cardioversion. So all these three things, if you have a patient who is coming to your emergency, who is suddenly unresponsive, and if you find any of the three ECG, your goal is to shock. So these three are shockable to them. So this is a ventricular tachycardia, and this is a polymorphic ventricular tachycardia, and this is a ventricular fibrillation. So if you find any of these three things, your aim has to be shock the patient, give DC cardioversion. Or if you find any of these two, so what are these two? You can see some complexes here, or some different complexes. But if you see is echo, or if you see this heart won't be contracting. Only few electrical complexes will be there, and but no heartbeat. When there is no heartbeat, there is no pulse. So this is a pulseless electrical activity. Okay, what do you see here in this? There is nothing. There is no waveform, just some fluctuations. That's it. So this is an example of asystole. So when you have these two rhythms, then these are non-shockables. So this is where you cannot shock the patient. You should do CPR with adrenaline. So this is the difference. So if your patient comes to the casualty with any of the first three ECGs, then you shock the patient and then plus CPR plus adrenaline. So, but if the patient is with the last two ECG, something like this, then there is no, it is not, you cannot do the shock. You have to do CPR and you have to give adrenaline. So this is the crux of ACLS. So when do you shock? When to non-shock? So these three, such a wide complex tachycardia, any wide complex tachycardia, in or in doubt, shock. Any patient with hemodynamic instability, that means the patient's BP is low, the patient pulse is not palpable, the patient is having pulmonary edema, patient is having other significant symptoms, then you have to go on cardio with the patient. No point in diagnosing, no point. You need not know this is ventricular tachycardia, this is polymorph VT. But if this ECG comes and the patient is hemodynamic unstable, and if you are the only doctor there, you have to cardio with the patient because diagnosis comes next. Treatment comes earlier in this set of patients. Leave the diagnosis to the cardiologist. You have to recognize the patient, act immediately. Think, see, recognize the pattern, and act immediately. So this is a summary of what we were saying. So if you find a patient with a cardiac arrest, first thing first, you start CPR. If you're in a hospital, you can definitely attach the monitor and give oxygen and connect the defibrillator. And then your job is to recognize whether it is shockable or non-shockable. So what are the shockable? It is if it is VT, monomorphic or polymorphic VT, or if the patient is having VF. These are all shockable rhythm. What is not shockable rhythm? If the asystole or a pulseless electrical activity. So this and this, they are non-shockable. So start CPR. Any of these three, it is shockable and you shock the patient immediately. Okay, so if we'll start with the shockable rhythm first, what will you do if you find this rhythm? First thing, you as a DC cardioversion. So you shock, and immediately after shocking, you have to continue CPR. You need not worry about what is happening to the patient, whether the patient is rhythm has comes to normal, or whether the patient is having for the continuing tachycardia. You don't bother about it. You continue CPR, and then after 2 minutes you reassess. If the patient's rhythm is still shockable, okay, if there's still shockable, then you do shock, then CPR, then adrenaline, and this is the adrenaline should be added. So that should be given second time. If it's still in the shockable rhythm, if you come after 2 to 5 minutes, then again you have to consider, you have to intubate the patient and you have to give adrenaline, and then you have to consider cardrone and lignocaine. Sorry, amiodarone and lignocaine should be considered, and reversible causes should be treated. So what you should do, you find a patient is coming to the casualty, you find a shockable rhythm, patient is unconscious, you are first cardioverting. After cardioverting, what do you do? The patient, you have to continue CPR for 2 minutes. After 2 minutes, what you do? You reassess whether the patient is still in shockable rhythm or not. If the patient is still in shockable rhythm, you again give a cardioversion, give CPR, give adrenaline. If again, even after 5 minutes, the patient is still in shockable rhythm, then repeat the shock, give adrenaline, and give other drugs. These are the drugs you should give. Amiodarone and lignocaine should be given in such patients. So, how should you do CPR? As I said earlier, it should be 2 inches. It should be 100 to 120 centimeters. No interruption, no excessive ventilation, and change the compression every 2 minutes. You have to keep changing. The one guy who's giving the CPR should go on bag, because bagging is a little less energy consuming, but CPR will be more tiring. So once you are giving CPR, and after sometimes you get tired, you have to go and give the bag and mask, and let that other guy come and do the CPR. If there is no advanced airway, that is to do compression ratio should be maintained. So then DC cardio version, which I said, it should be either monophasic or biphasic. If it is monophasic, which is the older one, it is not currently do, 360 joules should be cardioverted. If it is biphasic, 200 joules should be given. And the drugs, the three drugs, the adrenaline 1 mg every 5 minutes, the amiodarone, which came here. Okay, amiodarone will be like 300 milligram bolus and 150 milligram for the second dose, or lignocaine 1 mg per kg bolus, followed by 0.5 mg per kg second dose. So just three drugs: adrenaline, amiodarone, and lignocaine. Adrenaline, first attempt only you should give. If the adrenaline if doesn't respond, then amiodarone or lignocaine can be given as considered second or third drugs. So this is for a shockable rhythm, that is a VTR polymorph VF. What if it is an asystole? What if the patient is having this ECG or this ECG, and you are seeing the patient unresponsive lying on the bed? Then what do you do? Then you have to give adrenaline immediately, and CPR immediately. Adrenaline is ASAP. This is actually a change from the previous guidelines. Previous guidelines did not have adrenaline here. Now you have to bring in adrenaline very early and continue CPR also very early, and then repeat adrenaline every 3 to 5 minutes. And if you need the patient, you have to intubate the patient. So then you reassess after 3 to 5 minutes if the patient is in shockable rhythm or non-shockable rhythm. So if it is in the shockable rhythm, then you shock the patient. If it is not in the shockable rhythm, you continue for CPR and look for reversible causes. So what is the reversible cause? This is the reversible 5H and 5T. So hypovolemia, that means low blood volume because of diarrhea, vomiting, or some blood loss, something can be there, and that should be corrected. You have to replace with fluids, or you should replace with blood. And hypoxia. Hypoxia literally means your oxygen saturation is too low. You correct it with oxygen, or if you correct it with intubation, or all those things. Acidosis, if it is significant, then you have to correct it with sodium bicarbonate. If there is hypo or hyperkalemia, then that should be managed appropriately. If there is hypothermia, then they should be managed appropriately. So this 5H and 4Ts, like cardiac tamponade. Tamponade means outside your heart, there will be significant fluid accumulation, and that will compress your heart and you will have hypotension. So tamponade should be managed. Toxins. Some patient could have taken some unusual tablets or toxins that would have caused his hypotension, or unto thrombus, the pulmonary thromboembolism and coronary thrombus. That is your MIs. So MI, pulmonary embolism, toxins and tamponades, and 5H, hypovolemia, hypoxia, hydrogen, that is acidosis, hypothermia, hyperkalemia, and tension pneumothorax. So, so many things would have come to your mind and would have got confused. I will just simplify it. Just if you're not previously understood, just listen to these things. You go, you see a patient unresponsive lying on the table. First, check the rhythm. If it is a shockable rhythm, shock, CPR, adrenaline. Look for 2 minutes. If there is no response, repeat shock, CPR, adrenaline. Then till the patient improves, you should repeat that. A third time, you have to add amiodarone and lignocaine. This is the first group. Second group, you see the patient. Patient is having unconscious and his rhythm is non-shockable. Then what do you do? Just take shocking out, CPR, adrenaline, and then correct all the reversible causes. So this is it. This is your crux of ACLS. So when you should stop, this is very important. Once you achieve this return of spontaneous circulation, that is when you stop resuscitating. So what does that mean? It means your pulse and BP has improved. Your PETCO2, if it should be more than 40 millimeter of mercury, that means internal carbon dioxide volume has improved, and that means perfusion is good. So, and then your spontaneous arterial pressure waveforms in intra-arterial monitoring. So we commonly use this. So you keep giving the patient CPR or ACLS. If you could see the pulse, if the patient BP comes in, or if the patient becomes conscious and patient talks normally, that literally means you have achieved the spontaneous circulation. That if in advanced setup, when you put an arterial line and monitor, and if you get a BP waveforms, then it means pulse is back. Or if you do an PETCO2, if it is more than 40, that means your circulation has come back. So this will summarize our ACLS. We'll see few more ECGs, which we commonly encounter in such practices. These are tachycardia ECGs. So if you look at the ECG, first you have to look at the heart rate. You can see this is the, if you see, they are very narrow. Between the gap between the two spikes are very less. So literally means that heart rate is low, too high. If it is low heart rate, then it will come, one will be here, one it will go. This is bradycardia heart rate, this is tachycardia. So that is the first thing you have to identify. After identifying this is tachycardia, then the second thing should be, you can see this is the narrow complex. If you can see the QRS is just just two small boxes. If it is more than 120 milliseconds, or if it is more than three small boxes, then you have to consider it as wide complex tachycardia. If it is less than that, it is narrow complex tachycardia. So we found it is tachycardia, then we found it as a narrow complex tachycardia. Then you see before the QRS there is no P waves. Here a normal ECG will be P followed by QRS and T. Here there is no P. So these three findings, there is no P waves, narrow complex tachycardia, and heart rate is around 150. So this is an example of SVT, supraventricular tachycardia. More commonly we call it as AV nodal reentry tachycardia. When you find this ECG in a patient, then you have to use different drugs. So this will first respond to vagal maneuvers. So what is vagal maneuver? That literally means something which improves your vagal tone, your cardiac sinus massage. That will do, or used to, a lot of movies would have seen. They would have pushed some cold ice on his face. That will trigger a vagal response. So it will be vagal maneuvers. If there is no response to vagal maneuvers, then go give adenosine. Adenosine should be given 6 mg. If there is no response, 12 mg. If there is no response, one more 12 mg. There is no response to three drugs, then you have to go for IV beta blockers or IV calcium channel blockers. Either of the two will do. Having symptoms, significant symptoms because of the arrhythmia, you cardiovert. The patient is asymptomatic with only having some palpitations. Then you can consider this vagal, adenosine, or beta blocker or CCB. If that is not there, you directly cardiovert. So this is an AVNRT. Now you compare this ECG with our next ECG. Uh-oh. Am I audible now? Raghu? Am I audible now, Raghu? Neeharika?
Sir, you're audible, sir.
Okay, okay. Can we proceed?
Yes, sir.
Yeah, yeah,
Sir, audible.
yeah, yeah. Okay. Next thing, you look at the second ECG. Sorry for the disturbance. What is the difference here from the previous ECG? You can see the same thing. It's a narrow complex.
The screen is not
The heart rate
visible,
is,
sir.
sorry.
Screen is not visible, sir.
Okay. We, is it now? Is it visible now?
Yes, sir.
Okay, fine. Now you look at this ECG. On what is the difference you are seeing in this ECG? So you can see this is a narrow complex. It's not wide. And second thing is before the QRS complex, there is no P waves. There is no P waves. And third thing is, if you can see, the QRSs are all not regular. Sorry. This is not. Something with the internet. How is it ready? So 3 findings are there in this ECG. I'll just do it quickly. First thing is that you can see the RR intervals are not regular, not like our previous ECGs. If you see here, the RR intervals are at a regular space. You see this ECG, one hour is here, 1 hour is here, and then you have a long gap. You see this gap is narrow and this gap is wide. Such irregular QRS complex plus no P waves. This is suggestive of plus narrow QRS, suggestive of something called as atrial fibrillation. Okay, so atrial fibrillation ECG is 3 things: narrow QRS, irregular RR interval, and absent P waves. Here it was 3 things. It was narrow QRS complex, heart rate is more than 150 with no P waves, but this was regular QRS complex. Here it is irregular QRS complex. So this is the difference. And third ECG, and this is also, you can see it is a narrow QRS complex and heart rate is very high. It is around 150. The unique finding here is that you can see the P waves. You see these 3, 4 P waves, all are looking different. So this is small P wave, this is a large P wave, this is a large P wave, and this is a small P wave. So multiple morphology, more than 3 morphologies of P waves. So that we call it as multifocal atrial tachycardia. So something called as MAT, multifocal atrial tachycardia. So summing up, so any tachycardia, if you are in the casualty, you see a patient coming with tachycardia, and it is a narrow complex tachycardia. We previously saw wide complex, now it is a narrow complex tachycardia. Then what should you do from that point? First thing, you assess is patients, whether the patient is conscious, whether his airway is protected, or the patient is unconscious and you need to have to intubate him. That is the first thing. Second thing, you connect the patient oxygen and do a continuous cardiac monitoring. You connect the rhythm strip and look at his heartbeat and the monitor, start the IV access and take an ECG. So if the patient has, then ask these 5 questions. If the patient has any of these 5 questions as yes, then you cardiovert him. So what are the 5 questions? If there is is there any hypotension? Sorry. Is there any hypotension? Is there any signs of shock? Is the patient having chest pain? If the patient is in acute pulmonary edema with positive oxygen, or the patient is having altered mental status, the patient is not conscious. If there is any tachycardia that is causing all these 3 things, then you cardiovert the patient. If none of these things are there, then you consider the other management like vagal maneuvers, which I said earlier, adenosine 6 mg, 12 mg, 12 mg, beta blocker, calcium channel blocker. But it's not responding, then call an expert. If it is a wide complex tachycardia, when you see, you have to be a little bit more worried. Narrow complex can be benign or malignant. Wide complex tachycardia, in majority of the cases, is malignant. So this is what you see. All these ECGs, you have finding a narrow complexes. If you go back, you see something like this. So these are all wide complex tachycardia. If you find such ECGs, then I think you have to be very cautious. Definitely get a cardio or medicine opinion. If the patient is in shock, you shock the patient. If not, you can give this drug, amiodarone. This is like for if you are a lone doctor in a setup, and if the tachycardia, if you're not able to diagnose on the patient is not hemodynamically unstable, then this could help you in such suit. 150 milligram of amiodarone 10 minutes, because it's a wide range of spectrum is there. So any acute tachycardia which you are not able to diagnose, you can definitely use amiodarone. So you have seen all tachycardias. Now, the other reason a patient can come to casualty because of rhythm disturbance is the bradycardia. So bradycardia, I'll show you a few ECGs. So we'll start with the first ECG. What are you seeing here? First thing, which is obvious, is that all the previous ECG we saw, the QRS complex were very narrow. Here, QRS complex are very wide. So this is a wide complex tachycardia, bradycardia. This is a bradycardia. So your heart rate, you have to see 300 can be number of large boxes. You can see 1, 2, 3, 4, 5, 6. So this heart rate is around 50. So it is a bradycardia. So first thing you have found out is bradycardia. And second thing, what you find is that any bradycardia chase your P waves. See, in this you have here one P wave, here one P wave, and a QRS complex. This is a T wave. This is a P wave. This is the P wave. This is the QRS. This is the T wave. So P wave, QRS, T wave. P wave, QRS, and T wave. So every two P waves has one QRS complex. So this is an example of 2:1 AV block. So 2:1 means two P waves and then followed by a QRS complex. So this is an example of 2:1 AV block. It's an advanced AV block. And see the next, you can see this is the P wave, this is the QRS complex. Heart rate is okay, it is recent, it's around 60 beats, 60, this is around 70 beats. So you can see the PR interval. The P wave is there, R wave is there, is around 4 small boxes there. Look at the next.
Sir, not audible.
Students, kindly hold on. There is some technical difficulties and sir will be joining with us shortly.
Hello.
Yes, sir, you are audible now. So mic was turned off. Sir, not audible again.
Audible now?
Yes.
Yeah. Sorry. Sorry for the delay. And yeah, this is an example of Mobitz type 1 AV block, also called as the Winky bag phenomenon. And this is the third ECG. You can see the heart rate is too low. The QRS complex are too wide, and heart rate, if you see, it is just 30 beats per minute. And other thing you can see is look at the P waves. You can see multiple P waves. So multiple P waves with very few QRS complex. This is, what is the idea? This is a complete heart block where the QRS is happening independently, P waves are beating independently. But there is complete difference between the P wave and QRS complex. This is a complete heart block. When such patient comes to your hospital, what will you do? That is what you have to see in this update. See, same thing. When a patient comes to your casualty, his heart rate is 50 beats per minute, and look fast for symptoms of low heartbeat. If the patient is having palpitation, the patient is having shortness of breath, giddiness, syncope, any of these symptoms are there, then you have to label him as malignant bradycardia. Then in such patients, then look at the rhythm. If it is an advanced AV block, like a second degree or a complete heart block, then you have to be very active in its management. So if it is a yes to any of these questions, hypertension, altered mental status, shock, chest pain, breathlessness, then you manage effectively. Start atropine. Atropine you give 1 mg, wait for 3 to 5 minutes, look whether heart rate is increasing or not. If the heart rate is not increasing, then you repeat the atropine 3 times. Up to 3 milligram, you can give atropine. And or if it is not improving that, you do a transcutaneous pacing or trans TPI, which we do. We used to take access through your jugular vein, take a TPI device, it enter into the right atrium, into the right ventricle. You go and start pacing your right ventricle. Because such patients, if you give temporary support, mostly inferior wall MIs will have this complete heart block. And if you give temporary support till the heartbeat improves, the patient will do very well. So if atropine is not effective, then you have to give a transvenous pacing or a transcutaneous pacing. And if that is on, if you are in a setup which doesn't have that, then you can start dopamine or adrenaline. But again, these two things won't maintain your heart rate much. But if you're giving dopamine, you should give it a dose of 5 to 20 mg per kg, or adrenaline, it should be 2 to 10 mg per kg. This thing should be done. And if there is any evidence of MI, then that should be corrected. Myocardial infarction should be corrected in such patients. So third part, which is we have to know, is the drugs used in ACLS. So far, we have heard of so many drugs. The most important one amongst them is the adrenaline, because it's the only drug which can be used in almost every scenario, and is the only drug that has got high chance of return of spontaneous circulation. So adrenaline 1 mg IV should be given, and it can be repeated every 3 to 5 minutes. So 3 to 4 times you can repeat the adrenaline. So this is your wonder drug or the most important drug of the lot. Second drug is the atropine. The atropine, remember, has got no role outside of bradycardia. So suppose a patient has got, let's say the patient is having first degree or second degree or third degree heart block. Only in those patients, you can give atropine. Atropine was previously given a dose of 0.6 milligram, but now the recent guideline says 1 milligram. 1 milligram atropine, again, repeat every 3 doses and 5 minutes, can give up to 3 milligrams of atropine. So adrenaline is there, atropine is there. Amiodarone and lignocaine. Lignocaine is actually, it is more effective if it is an ischemic VT. The patient has got MI and then develops VT. You can search patients, you can give them lignocaine. And amiodarone can be given as a bolus, as a third line. If you see the flow chart, right, you start CPR, give adrenaline, shock the patient. If there is no response to that CPR shock adrenaline combo, then you have to consider amiodarone. Amiodarone can be given as 350 mg bolus followed by 150 mg. You have to give it. If the patient has got polymorphic VT, the image which I showed previously, come this. If this is the VT image on his this thing, then you have to give magnesium. So magnesium is also very useful. Magnesium should be given as 2 grams IV bolus. Only in this polymorphic VT it is useful. Other VTs we actually prophylactically give in most patients, but ideally it is indicated only in polymorphic VT patients. And your sodium bicarbonate. Sodium bicarbonate is another drug. It is given a dose of 100 milliequals. It is not given in all settings. It is particularly useful in 2 issues. If the patient has got very high potassium or if the patient has got significant acidosis. If any one of the 2 is present, then you can give soda bicarb. So these 3 drugs and doses you mug it up. Adrenaline 1 mg, atropine 1 mg, amiodarone 300 mg, lignocaine 1 mg per kg bolus, Maxelf 2 grams, and soda bicarb 100 milliequals. So these are the 5 common drugs that is used in emergency. In which drug, in which setting, that we have discussed already. So coming to defibrillation. So what is this concept of defibrillation? It is just giving the shock. What does happen here? See, basically, all these rhythm disturbance are because of some abnormal focus firing too much. So when you give defibrillation, what happens is that the entire heart gets depolarized and then it comes normal and the sinus node takes over. Because sinus node takes over, you cardiovert and then your rhythm stops and then sinus node takes over and your heartbeat becomes normal. So this is what is defibrillation and it indication of the shockable rhythms, which I have already said. It is just VT and VF. The VT can be monomorphic or polymorphic VT and VF. And there are three types of cardioversion. One is the manual, which we do in the hospitals and emergencies. You put both. You see the ECG waveforms, shockable. Then you make the decision and you shock the patient. That is the manual dissipations. The automatic is the one that is available in the malls and other public places, where you can stick the paddles and that will assess the ECG and that will tell you if it tells you shock, you shock the patient. That will help you. It is a guided one for basically non-healthcare professionals. And semi-automatic is a in between these two things. And then which we call as monophasic and biphasic. Monophasic is mostly obsolete now, not commonly used. The biphasic one is most commonly used. My recommendation is go for 200 joules. Any unstable VT, don't waste time diagnosing. Don't waste time going from low pressure to high threshold. Give maximum threshold shock. A 200 joule shock should be given at that point only. So how will you do it? As an image, there is a standard defibrillation. One in the anterior, one in the lateral aspect. You keep the paddles over this place. The monitor will record the ECG, and if it is shockable rhythm, you have to charge. There will be charge button. You have to charge it. It will take some 5 seconds to 10 seconds. Once the charge is full, then you have to press the deliver, and it will be delivered to the this thing. And before delivering, it is important to say clear. That means no one should be touching the patient. Sometimes we'll be giving the staff nurse will be touching the patient, or some other patient will be standing near the patient. So you should not be in personal contact with the patient. So once you keep before delivering the shock, you should ask your surroundings: is there anyone nearby? If everyone is saying I'm clear, you are clear, and you should also not be hanging. You should also be clear, and then
So
you
voice is not
give.
audible.
Sorry, voice is not audible. Is it audible now?
Yes, sir.
Yeah. Okay. This is the standard defibrillation. The other two things is the vector change defibrillation, where you keep one in the front and one in the back. This is what we do now. Most of the same patients, when they got everything, this is a better charge distribution. But similar, you can definitely go for standard defibrillation if you are a starter. Because this has like a lot of position changes are there. So you do the standard defibrillation is the most common. The third one, that is new one, is the double defibrillation. The two pads are kept, and it is told that this has got a better defibrillating one. But again, it is not available everywhere. You do the standard defibrillation one correctly and get the result. So once you have defibrillated, then what you should do? You should not just leave the patient there. You should not just be stunned. You start your CPR immediately. So 2 minutes you give your CPR, as we said earlier, and then you reassess the rhythm, and then you
Sir,
take it forward. So after assessing the patient successfully, what next from there? You have to maintain your two things. Your BP should be
sir,
maintained, your oxygenation should be maintained. So to maintain, yeah,
the voice is not clear. It's
audible?
audible but not clear. It's audible but not clear.
Oh, okay. I don't know. So keep your pressure more than 65. Mean aortic pressure should be more than vasopressors like noradrenaline, dopamine, adrenaline. Use all agents to keep your NAP more than 65. Norad is the most commonly used drug. So keep your mean aortic pressure more than 65. And then second target should be your saturation should be more than 92. So that you use oral airway, bag and mask ventilation or intubation. After maintaining saturation, do an ABG. In ABG, your carbon dioxide
Sir, again not audible. Not audible.
Now is it audible?
Yes, sir.
Okay, sorry for so many breaks. I don't know why. Okay, then once the patient is resuscitated, after that you have to take a brief history and examination, find the exact cause. It could be cardiac, it could be respiratory, it could be secondary to drugs. Respiratory, it's basically a COPD exacerbation or bronchial asthma exacerbation or a pneumonia or a pneumothorax or pulmonary embolism. If it is due to electrolyte disturbance, probably hyperkalemia or hypokalemia. If it is because of intracranial hemorrhage or ruptured aneurysm or pulmonary embolism, then those should be found as after you resuscitate the patient. One of the other important thing in ACLS is the temperature control. You keep your core temperature between 33 to 36 degrees centigrade for 24 hours. This is hypothermia. You create hypothermia to prevent your brain injury. Not for all, only when the patient is having for GCS or this mild brain injury patients, you keep it at 36 degrees centigrade. If it is severe brain injury, you keep it at 33 degrees centigrade. You can use cold saline or ice packs to do the same. And if the patient has evidence of any aspiration, or the patient is having, if you visually seen the patient having aspiration, then you have to give the patient on empirical antibiotics for the treatment of aspiration pneumonia, and keep the blood sugars between 140 and 180. That is also very important. That is whatever I've discussed here is what is summed up here. And finally, you should know when to quit or when to stop your resuscitation, because you can't keep on doing the resuscitation. So if it is taking more than 30 minutes, if you are resuscitated for more than 30 minutes and if there is no sustained rhythm, then you have to call it off and you should start declaring the patient. If the patient is having unwitnessed collapse, initially ECG is asystole, and if you have a full-blown dilated pupils, if it is not responding to any your stimulations, then you have to call the patient then. And then if the patient if there is long period of time, the collapse in the starting of the CPR, then also you should stop the resuscitations. And then this is the another example. If the ETCO2, if you measure, if it is less than 10 after 20 minutes of resuscitation, then also you can stop the resuscitation. So basically, when you have resuscitated for 30 minutes and if you are not able to receive there is no return of spontaneous circulation, no pulse, no BP, then you have to quietly call it off. So I will summarize what you have to do in an ACLS nutshell. See, MBBS students who I think is the primary audience here, there is two things to this. First thing is knowing what to do. Second thing is actually going and doing it. You will get a grip of ACLS only when you start doing it and start seeing it in the patients. But before doing that, that is not the place to think. In casualty and see your seniors. How are they resuscitating? That is the best way to learn ACLS. Know the theory, go to your casualties, see your seniors resuscitating, ask them, and you go on cardiovascular 2-3 patients. That is the only then you will have the absolute confidence. So you read what is ACLS 2020 guidelines is there. You can read about it. If there is any other doubts or anything you need me to clarify it, I will definitely clarify it. So I think, yeah. Will sum up now?
Yes, sir.
Yes, sir.
Okay. Anything specific, like any doubts or anything which we need to explain in a little bit further? Maybe I can do it. Sorry for the bad connection. I think some rain and web connection was disconnecting and reconnecting. So that's the issue.
No one has asked the doubt, sir.
Okay. Okay. Fine, Raghu. Then yeah.
Thank you, sir. Thank you so much. It was really a wonderful presentation, sir. I
Thank
think
you. Thank you, Raghu.
around 200 plus students have watched through YouTube. So this will be,
So,
and any doubt, if at any point of time, you guys can even put it in the comments so that sir can answer it in the future. Niharika, you can go ahead with the vote of thanks.
Yes, sir. Thank you so much, sir, for such an insightful and impactful session. I'm sure we will walk away today with a much clearer understanding of ECG and ACLS and a deeper appreciation for their real world importance. A big thank you to everyone who joined us. It's your energy that makes this session truly meaningful. On behalf of Medusane, we hope this is just one of many more enriching experiences to come. Stay curious, stay connected, and until next time, keep learning. Thank you and have a wonderful evening.
thank you.
Thank you.
Thank you for the lecture, sir.
Yeah, yeah. Thank you. Thank you.
Session end, Panta, sir. Thank you, sir.
10:20.
I'll call you.